It's our great pleasure to introduce Sanjoy Bhattacharya, who will be speaking about his recent article and his current research on the historiography of international and global health. Sanjoy is the director of the Center for Global Health Histories at York, where he's been since 2010. And previously he was at UCL as a welcome professor, is that correct?
Reader, yeah.
A welcome reader. And he's done really fascinating, very important work on the history of the WHO and smallpox in particular.
Thank you. Thank you for that, Julia, for the invitation. So I'm currently working on a history of primary healthcare from a sort of national, regional, and global perspective. But during one of my stints at the WHO archives in Geneva, I came across about 3 or 4 boxes full of stuff that had been misfiled in the India files and actually dealt with Bhutan, which I found very interesting because when I had written my book on smallpox eradication in India, I hadn't come across the Bhutan file, so someone clearly had sort of reorganized the material, and so I decided to spend 24 hours just going through, 2 days, just going through the material, and what I read surprised me and also made me realize that my book would have been much richer if I'd found these boxes. And then some of the stuff was so controversial that I couldn't let this material sit. So I then sort of went back to Geneva, spent about 10 days photographing whatever I thought was useful. And the article that I wrote on the smallpox program in Bhutan is based on that research. Now, although Bhutan is a tiny little sort of country to the north of India, a very important sort of country for India because China is on the other side, what the Bhutan case study showed me is that there is a lot in the history of international health that just ignores the ground level complexities of the implementation of programs. A lot of the history that's written is often about plans, it's often about stated goals, but a lot of history, international health history, doesn't actually look at the nitty-gritty of the field conditions. And looking at the Bhutan case study made me realize that there were some things that historians of smallpox eradication had missed, including myself. So this was an article intended to redeem myself. Right? So let me set this sort of scene with 3 interpretations of smallpox eradication, which I think will give you a nice sense of the biases that continue to prevail in this wonderfully positive story. It's still the only human disease that has been eradicated. I mean, we've been promised polio eradication for some time, and even though the goalposts have been changed, making the definition of eradication easier, so eradication should really have happened, but it hasn't happened, and we can discuss that later. So the first interpretation is what I would present as the WHO headquarters interpretation of smallpox eradication. It refers to the Soviet Deputy Minister of Health, Viktor Zhdanov, who was a virologist standing at the World Health Assembly podium in 1958, and he proposes eradication. Why does he propose eradication? Because he's able to demonstrate with data available to him that the USSR had been able to stamp out smallpox within its territories, but the disease would keep coming back from neighboring countries like Afghanistan and Iran. And his argument was that if the USSR, with its massive military spending and massive medical spending, could not prevent the disease coming back, there had to be another way to stamp out the disease. And that other way was international cooperation. so that if, regions started getting rid of smallpox, then it was easier for nations to keep their smallpox-free status. According to this interpretation, it's a very honest interpretation in many senses. It acknowledges that it took 10 years just to get the project off the ground. Money, vaccine, people, political commitment all took time to sort of mobilize. But once that was mobilized, according to this interpretation, WHO consultants and models proved to be the basis of global action. This is not me, this is the WHO Histories claiming that their models sort of provided the blueprint for what happened internationally or globally. I mean, both terms are used in the paperwork. The last case, as you might know, was in 1977, and according to the WHO, in 1980, an international committee drawn from both sides of the Iron Curtain and people from developing countries and people from less developed countries formed an independent certification committee chaired by an Australian epidemiologist, and in 1980 this committee, after looking through evidence, epidemiological evidence and other sorts of evidence, oral sort of interviews with actors, decided that the world was truly free of smallpox, and therefore the WHO made smallpox eradication possible. But there is a dramatically different interpretation that sits uncomfortably side by side to this day with what I've just told you. And that comes from Atlanta, the Centers for Disease Control in Atlanta. And according to this narrative, this story, this interpretation, in the early 1960s, because of sudden American political interest in Western Africa, especially decolonizing Western Africa, Francophone Africa, the CDC sent a rather large group of young men, as some people put it, because they didn't know better, to go and trial a smallpox and measles sort of immunization program. According to this interpretation, US government support, CDC support, made it possible for these people to sort of experiment with new ways of carrying out sort of ring vaccination, to create new types of surveillance networks, basically create a new way of doing preventive medicine. That then allowed Western Africa to be rid of smallpox. And those models, according to these interpretations, were then exported wholesale across the world, and then informed global action. And therefore, some of these books have unfortunate titles, perhaps Sign of the Times, Crusade Against Smallpox, and things like that. But according to all these publications coming out of the CDC, it was a Western Africa experience that set up global smallpox eradication. But let me give you another interpretation. The interpretation that the Indian government tried to publicize for a little while. And I'll later explain why it was only for a little while in my view. Now, if India had not been part of the eradication program, there would have been no global smallpox eradication. Year to year, India contributed more cases of smallpox and the most virulent form of smallpox than any other nation in the world. So you couldn't have a global program without India in it. So, in a sense, when the intensified global program starts in 1968, a lot of the world is not involved. It's a global program, but focused on Africa and Asia, really. But, again, raises important points of how we define the word global. So according to India's official history, India had a long history of vaccination for hundreds of years. India had vaccinated. Of course, they were not daft enough to say that all was well during the colonial period, so this historical interpretation talks about shortcomings during the British era. But what it does then immediately go on to claim is that there was excellence after independence, the day after independence, suddenly things turned around. I mean, I'm joking. But But the main theme that comes across in this interpretation is the fact that India was a partner of the WHO. India was not being led by the WHO. India was not blindly following WHO directives. The CDC involvement does not even get a mention. I mean, that's not a surprise considering India is very close to the Soviet Union. Those people who were seconded from the CDC are referred to as WHO officials. They are not referred to as CDC officials. But what these histories, this official history from India highlights, is the importance of local contributions, the contributions made in relation to vaccine, ideas, staff. The numbers are constantly highlighted. The fact that at any point of time there are only about 1,000 foreign workers in India, but 100,000 Indian public health workers is constantly being highlighted, just to show how important local contribution is. And of course, what this history is underpinning is this claim that India is becoming a regional power, a global contributor in the late 1970s and 1980s. So again, this is a history with a political goal, a history that is underpinning a much bigger claim. Now, if you look at these three types of histories, from my perspective, I like to divide up the histories in sort of different categories. The first category I'd like to mention is what I call a static international history, or static international histories. So, what do I mean by this? So, the WHO, for instance, it is very notable under Habdan Mala, who was then the Director General of the WHO, celebrates the smallpox eradication achievement and then quickly moves on. Why does he move on? Because his pet program is primary healthcare. And Mala, in unpublished correspondence, I mean publicly and in published correspondence, he's of course always very supportive of smallpox eradication. But in unpublished correspondence, he actually sees vertical programs directed at one disease as being damaging to national healthcare needs, or indeed international healthcare needs. What he prefers is sort of the development of general healthcare mechanisms, which for him was primary healthcare. So he says, okay, done and dusted, we've eradicated smallpox, now let's focus our energies on primary healthcare. So that's one reason the smallpox history is downplayed. In India, there are many reasons to downplay, not, linger too long about the smallpox eradication history, because nasty things were happening in India during the last phases of the smallpox eradication. The so-called emergency when Prime Minister Indira Gandhi basically annulled Parliament and ruled like a dictator is around the same time when smallpox is being eradicated in India. This is also a period where India decides it has a population problem suddenly, and that the Muslims in India were the cause of that problem and started pulling off young Muslim men off the street and forcibly sterilizing them. So you have all sorts of nasty things happening. So of course when smallpox is eradicated, you celebrate, but you don't linger too long on how it was done, because people can start asking questions. In East Pakistan, Bangladesh, there are coups, very bloody coups. The person who's called the father of Bangladesh, Mujibur Rahman, every member of his family is slaughtered except one daughter who happened to be outside Bangladesh that day. There's Cold War politics at play. America supports that coup. India, which had been very popular before that coup, as had the Soviet Union, suddenly find that they have very little influence in Bangladesh. So again, people don't really celebrate smallpox eradication for too long in Bangladesh, because no one wants to talk about this very, very bloody internal political history. But I also feel that there is an incomplete silencing, because you can stop talking about smallpox eradication in political circles and funding circles, but no one could ignore the fact that a disease had been eradicated for the first time ever. And therefore, that momentum in international health resulted in the formation, actually not the formation, the expanded program of immunization had been formed beforehand, but it resulted in the strengthening of the expanded program of immunization. And the EPI people within WHO, within funding bodies, within the World Bank, within all sorts of sort of important policy circles, would not let people forget that smallpox had been eradicated because of a vaccine. So, power of technology. Then I'd like to create another category, that is histories on the move. So these are not static. And this group of sort of history writing was encouraged by the demise of the primary healthcare idea as espoused by Havdan Mahler from within the WHO. That's another story. That's what we're studying right now. But what happens with the demise of primary healthcare is that EPI, the expanded program of immunization, becomes more powerful, as do other programs within the WHO, which make it expedient to suddenly remember smallpox eradication again. And it's not an accident, I think, from what I've seen in the archives, that this big red book on the eradication of smallpox, which was published in 1988, which people still refer to when they're working on, looking for basic facts for the smallpox eradication, was published the year the polio eradication program was launched. So there is a definite political purpose to suddenly remembering the success of smallpox eradication. But at the same time, these are also constricted histories because there are national pressures. I've been very fortunate to be able to read the first draft of this book. Then different chapters were sent to different powerful countries like India, for instance. The health ministry then made notations and sent it back to the WHO. And then being able to see the first draft, the notations, and the final draft tells me what was silenced. And it's fascinating. A lot was silenced by almost every country in the world. But this is also the type of history that is used for institution building. The CDC, the Centers for Disease Control, is very good at institution building through history, although they would never acknowledge that they actually think history is useful. They actually find it problematic. But they're actually using it all the time for institutional building. And one of the reasons there's sort of discord in the ranks of ex-CDC officials who are working for the WHO is that the West Africa chapter in this book is actually, I think, number 14 or 15, which really annoyed people in Atlanta because they wanted that chapter to be the number one. That's where it all started. But so again, how you sequence chapters is very political. What you have after that is the rise of participant histories for a variety of reasons. A lot of people growing old, a lot of people who want to produce memoirs. So far, so good. But a lot of these participant histories also have a political purpose, in my view. I've given you just two covers, and they're one by D.A. Henderson, one by Bill Hagee. They're variable in quality. They're mainly memory as history, and of course, there are tyrannies of memory that then influence the way some silences are worked into these histories. There's a conscious silencing of controversies. There's a making of heroes. There's an unmaking of heroes, sometimes consciously, sometimes by default. D.A. Henderson's book sometimes salutes the nameless, but doesn't really mention too many local workers in any context, nor does Fege's book. But what strikes me as a critical, independent historian writing from a distance is there's a lot of worshipping going on, and this is, for me, really history as contemporary politics. This is the sort of history that Obama quotes when he gives an ex-smallpox worker a presidential medal. This history has very definite uses. But with the rise of participant histories, you have a new type of academic writing, or writing that seeks to present itself as deeply researched and academic. There's, of course, variation in quality there as well. But I find increasingly a symbiotic relationship between this new genre of academic writing and the participant histories. Suddenly, the participant history is seen as the fountain of truth. There's no need for many of these academics clearly to even go into the archives and study very complex happenings on the ground, or indeed talk to national participants of smallpox eradication program, of the smallpox eradication program. It is academic work that ignores complexity. There's strikingly mutual admiration. A book like the one whose cover I scanned, The Angel of Death, quotes widely from participant histories, but if you flip the book around, the main admiration, the advocacy comes from the people who wrote this participant history. So there's something going on here which we academics are not, they should be brought to task. We're being too polite about it. But these are also academic histories that bid a convenient farewell to inconvenient truths. So what is the result of all this? In my view, it's causing an entrenchment of myths. As we walk away from the archives, we walk away from careful research, we walk away from the recognition that there is a variation in policy, that there are histories, not a history. That goes hand in hand with an entrenchment of myth, and it's a general problem in the history of international health. And the problem is that even people who feel that they need to challenge the CDC history or the WHO history are working with simple binaries. And why are they working with simple binaries? I feel that they will often accept the CDC claim, or they will accept the WHO claim, so that they've then created a straw man who then they can attack to put forward an alternative political argument. But that is also preconceived history writing. So when you have some of the most critical, thoughtful, brilliant historians buying the simplifications that the participant histories are proposing to us, simply so that they can then attack that viewpoint to propose the importance, let's say, of Havdanmala or primary health care, then you're missing a trick. You're missing a trick because you're not studying the variations. I mean, some things clearly worked in some locales, which have public health users today. That is ignored as well. Sometimes there's there are local power relations that really cause resistance. That is ignored as well. Basically, good history writing, complex history writing is the victim. Again, my problem with this sort of history is that it's history as politics, not history as an academic discipline where, I mean, we all have biases, but it's important at some point to leave our biases, struggle to leave our biases to the side as we study complex and enormous archives. Now, what are these enormous archives? There are vast quantities of unpublished materials containing day-to-day correspondence. There are drafts of reports. There are private and confidential sort of files. And this is where I have a problem with historians who see smallpox eradication, have seen smallpox eradication through the prism of ideas. When they're looking at people's ideas, they're looking at published materials, but they're often ignoring the fact that although a 1975 report says something, privately and in confidential correspondence, that person is actually saying something very, very different, which suggests to me that the universe of ideas is complex, it is deeply political. There's a silencing going on, so you need to study both. You can't just rely on published reports. And again, there is a tendency, and increasingly I'm beginning to believe this is because of deep-seated Eurocentrism and US-centricism, there's a refusal to believe that WHO is not equal to the building that sits in Geneva. The WHO has always had regional offices. The regional offices have always been very powerful. The regional offices have always had budgets of their own. And this complete ignorance of what the many regional offices are doing and writing WHO histories on the basis of what's being discussed or being thought about in Geneva. Initially, I thought people didn't have access to the archives. Now that you have more and more archives being digitized, they're still not using it. So it has to be something deeper. And I figured, if I have to annoy my fellow historians by saying you're Eurocentric and you're Eurocentric, go and do some more research, maybe they'll go and do it. But now they're dealing with other massive terms like the global south, as if everywhere in the south had the same level of development, or indeed as if the entire industrialized north was developed. I mean the great thing about the social determinants report that was brought out, a report on social determinants of health, showed that Britain, for instance, had Liverpool, there were neighborhoods in Liverpool that had levels of malnutrition that were equivalent to the worst cases in India. So, there are variations both in the so-called global north and the global south, but, the moment you deal with these massive terms, local complexity is lost. Now, as these participant histories start, other things start happening. Simplistic history allows for a lot of things. It allows for simplistic celebrations. I must say that statue that now stands outside the WHO, there were a lot of debates about how that statue should be designed, about the race of the people, about who's being vaccinated, who's vaccinating. And it's supposed to be quite a neutral sort of thing. You're not really supposed to know whether, who's Asian, who's Caucasian, who's African. But there are then these photos that are also distributed of Margaret Chan, current Director General, standing in the middle, holding D.A. Henderson's hand, and then also holding Hafdan Mala's hand, everyone smiling at the camera. We're supposed to believe that, that's enough. But, so many people have smiled at each other during the polio eradication program. If that could eradicate polio, it would have happened by now. It hasn't happened. So clearly, this again has a political purpose, and we can discuss that later. But these are two people who often didn't speak to each other during the height of the smallpox eradication program because their priorities were so different. So it is very important, I think, for historians or other arts and humanities scholars, or indeed quite useful social sciences colleagues, also to look at the archives, because one of the things that the Bhutan article showed me was that epidemiology was not objective. It was very, very subjective. There was silencing of data, which was more difficult in India because India was actually quite powerful compared to, the CDC official working for the WHO. What happens in Bhutan is very, very different. And it's not different because the WHO necessarily wanted it that way, or WHO headquarters in Geneva, or the regional office for Southeast Asia. But Bhutan was a country where there were thousands of Indian troops secretly sort of located there. India had just been beaten rather dramatically in a war by China. India was terrified. A lot of people assumed that India's nuclear weapon was directed at Pakistan. It wasn't. It was a lot of nuclear research. The bomb India produced was because of its fear of China and Chinese military might. It was also useful to scare the Pakistanis. That's a different matter. But it was a fear of China that made India think it needed a weapon system that would prevent future wars with its giant northern neighbor. So India sends this army in. It's supposedly a training mission, but there are battalions all along the China border that no one is supposed to know about. But the WHO and the UN knew about it. just didn't talk about it. Why didn't they talk about it? They didn't want to annoy India. Why didn't they want to annoy India? If India left the global smallpox eradication program, there would be no smallpox eradication program. So what then happens is India starts calling the shots. India says, okay, you want surveillance, you want search for smallpox cases in Bhutan, we'll do it. We'll send our people. No WHO foreign official is going to go in. WHO headquarters initially sort of says, are you sure? Maybe you need our help. And then people in Geneva are reminded about protocol, and suddenly everything becomes very quiet in the WHO regional office in Delhi and Geneva, and India is allowed to do whatever it wants. So what does India do? India launches a search mission in the central and southern parts of the country. It does not launch a surveillance mission in the northern part of the country where the Indian troops are. It then says that there are some cases, really, nothing very important. We found it, we've dealt with it. It's, no one needs to fear. The world doesn't need to fear about the smallpox cases in Bhutan. Problem, however, was an American worker who I write about, a young American worker who strikes up a personal relationship with the Bhutanese royal family. And it is clear from the paperwork in those 4 boxes that I mentioned that the Bhutanese royal family at this stage is trying to escape the clutches of Indian political control. So they're trying to develop international relations, they're making a case for Bhutan joining the United Nations. As part of this, they want to link up with people who might have links with international health and the WHO. So the Bhutanese royal family does something extraordinary for that period. It invites this young American gentleman in and gives him access to data that they are able to collect through local village headmen. And that epidemiological data shows that there actually had been thousands of cases of smallpox. At a time when even 500 cases of smallpox was considered a serious outbreak. So again, this is the importance of time and place. Yes, 3,000 cases of smallpox might not have been a big deal in 1968 because India had 20,000 cases. But by the 70s, when the smallpox cases was falling, 3,000 cases was a big deal. So there is an attempt by Geneva to try and investigate these cases. The regional office slaps them down. This is what I mean. You have a regional office slapping down the headquarters-based staff, saying, "No, we're going to have a problem with a major national ally." You have local WHO workers working all around Bhutan and Indian provinces who are constantly sending in field reports saying, we've identified smallpox in Assam, we've identified smallpox in Bihar. People are saying that they had epidemiological links with Bhutan. We think there might be cases in Bhutan. Can we investigate? Again, no, you can't go into Bhutan. Only Indian army personnel, military and medical personnel can go in. Now all this disappears in the big red book that I showed you, Smallpox and its Eradication. In fact, it peddles some very dodgy claims. It claims, the big red book claims, that an international committee also looked at what happened in Bhutan. It didn't. The chair of the committee who looked at India, who was Eastern European, was not allowed into Bhutan. The Director General of the Indian Military Medical Services looked into the Bhutan case study. Why is that so extraordinary? Because that was the man who was also leading the Bhutan smallpox eradication program. So we have a case where the people who are doing the work, who are saying there's no problem, don't worry, no one needs to come here, is actually also evaluating their own work and certifying the country free of smallpox, which then allowed the WHO committee to claim the world was free of smallpox. So we have a problem of epidemiology here because the numbers publicly are changed. And why do I find that strange? Because privately, the numbers that are collected through the sort of connections that the royal family has is actually used to go to those villages to see if small cases happen. So privately, they believe in those numbers. Publicly, they say rubbish, these numbers do not matter. So, I'm sure it'll annoy some of my health sciences friends and colleagues who keep telling me about the importance of systematic reviews, but then systematic reviews are reliant on epidemiological data, and you can clearly massage figures. So I'm not saying systematic reviews are completely useless. I'm saying they're important, but hey, epidemiological raw data is deeply subjective, and we need to devise some sort of mechanism where we can look at local political, social conditions and to understand if data massaging in relation to specific diseases could have happened. And that is, I think, of current policy relevance. And how is it of wider relevance? Well, primary healthcare currently, historically, has always relied on robust epidemiological data. But what the smallpox papers also tell us, because the smallpox program is an active competition with the primary healthcare program, is just like smallpox eradication had multiple meanings for multiple actors. Primary healthcare too had multiple meanings for multiple actors. There are many ideas and origins, just like smallpox had many ideas and origins. So did primary healthcare. And where there was local stakeholding, it seemed to work. And where there was none, where it was imposed, it seemed not to work, which has fascinated me, which is something we're trying to study now. Often, historians who fall prey to the political debates that are going on in the WHO and refuse to study WHO and its complexity presume that the main fight is between the vertical program and the horizontal program, that is primary healthcare versus disease eradication, so the big battle currently between universal health coverage and polio eradication. It's not necessarily true. Sometimes the most effective programs, when one disease like smallpox or polio gets a lot of money, is other vertical programs. So the campaign that came out very badly, thanks to support to smallpox, was actually malaria. And then there are many other diseases, depending on different locales, that came out badly because they got less money. So what the smallpox project and the current primary healthcare project is showing to us is that there are shifting stages, but they're not seamless. There are a lot of grey areas that have not been studied by historians, nor have they been studied by policymakers. There are striking continuities that are often downplayed. There's an assumption often is that, the smallpox person would have then gone into the expanded program of immunization. Not strictly true. Look at the case of Bangladesh. Most of the people who ran the smallpox eradication program became the managers of the new primary healthcare program. So we have to study localities. We cannot deal with South Asia as if it's one homogeneous brown mass thinking and working the same way. You can't even generalize about India, leave alone the whole South Asian subcontinent. And there are striking continuities. Now, I've added this last bit in red because I've presented this paper in 2 or 3 other locations. And they've told me, but you're saying that we're not, that you're claiming we didn't say the local was important. Our work has said the local is important. I don't say that. I actually take fundamental issue with how they define local. Without naming names, recently I was approached by a research group in Paris that wanted me to be part of a collaboration. And I said, I like collaborating with people, but tell me, why do you want to work with my center? And they said they needed someone local. So then I wrote back and saying, I thought you wanted to work in India. They said, yeah, but you're local, you're Indian. So I said, no, I'm not local, I'm not Indian. You want to work as someone local, go to an Indian university, look at the... So we need to, as we think about global, we need to think about the local as well. Just because the WHO expert committee has 3 people from India, 2 people from Sri Lanka, 1 from Pakistan, and then you study that report and use it in your book, doesn't mean you have looked at the local perspective. Again, these are the elites from the capitals of India who are being seconded by the national governments for a political purpose to WHO to write reports. Expert committee reports start with the disclaimer, such reports should not be viewed as the WHO viewpoint. But that's ignored by the historian. This is presented as WHO policy. So for me, the local is a nitty-gritty. The subdivisional towns, the villages, where I ate stupidly and I had endless diarrhea attacks, but spoke to many times to many public health workers to make sure they were telling me the same story over and over again if there were problems, and then testing what they were telling me with what was available in the archive. Just to make sure that the tyrannies of memory weren't going into the way of complex history of writing. So as we think about the global, and some historians who like to dabble in simplification see it as a menace, we also need to, I think, rethink the local. I'm personally not a fan of the term global, but I think, a big project on unraveling the local, I think, is long overdue. So in conclusion, I'd like to highlight the fact that there are a great variety of theory and practice in all contexts. And we need to be aware of this as we are studying the international history of international health or global health programs anywhere in the world. It is so important to constantly compare publicly available documents with private correspondence. I mean, this is where I really like what the anthropologists do. The focus on the silences are so important. I see what exists historically in the past and today as an intricate mosaic, where elements of policy, ideas, they're constantly changing in shape, aims, and effects. So we have to be aware of the dynamic nature of the shifts of alliances, political, economic, social alliances. In fact, variations in resistance. All resistance was not the same. And smallpox shows us that very powerfully. It is very visible to us when we go to do our primary healthcare research to rural India, the villages of India, that there is a lot of resistance, different types of resistance to polio eradication as well. So I think what medical humanities can do, an alliance of sociologists, historians, anthropologists, political scientists, economists, who are sufficiently critical about our own disciplines and then also are constantly unforgiving about what we do as individuals, can actually work together to counter efforts at homogenization. Because for me, that homogenization is very, very dangerous because it's political and it has a certain purpose. And as academics, we need to fight those political purposes. Again, I'd like to point out, if you have that sort of approach, this generalization people make about the shift from the international to the global is problematic. The global, according to some historians, is supposed to represent the rise of the great funding agencies, the IMF, the World Bank, and apparently that caused international health to become global health. Not necessarily true. You're again then assuming that people sitting in DC are so powerful that at a flick of a finger they can change national attitudes, local attitudes. It doesn't quite work that way. So, in the end, I'd like to say that it's very important to look at the links between the national and the local, and then study their links with the sort of understandings of what is regional and international, and then what is now currently global. And it's a maddening sort of complexity of research, but very satisfying history to write in the end, not least because it annoys people in power who think they can say anything they want unchallenged. I think the role of the academic continues to be to challenge. So thank you.